Well, hello everyone, and thanks for joining this trauma care webinar. REBOA is a niche subject, but there's concepts that are hopefully of interest to the whole trauma community. The strapline to this presentation was current practice and what is the future of REBOA in the UK. I'm actually going to give you a general overview of REBOA and start by assuming very little knowledge, and hopefully there'll be something that most people can relate to, or at least get something out of this presentation. And I'll be delighted to take any questions at the end. I am a regular in the UK Armed Forces, but I don't represent military opinion in any shape or form. I've no financial conflict of interest to declare. And I think it might be helpful to declare that while I've got some vague familiarity with pre-hospital care, I'm not a pre-hospital specialist. You might have seen from my title slide, I'm a surgeon, a vascular and resuscitative surgeon. So I'm a hostage to my own experience, and everything is within that framework really. And so the main focus of this is going to be on hospital use of REBOA, but I will talk about pre-hospital REBOA to a degree. So the desire to stop active hemorrhage at all costs is compelling wherever you are in the world. Mortality data on those with major trauma hemorrhage is high. And this graph is indicative of UK mortality in trauma patients receiving massive transfusions. In hospital mortality is somewhere between 30 to 40%, as you can see on the graph, depending on the volume of PAC cells required. So in terms of damage control resuscitation, there's been developments and most notably via the Royal London Hospital. And if you've attended one of these webinars before by Professor Brohy, he's talked about that and the impact that those changes have made on overall survival, interestingly independent of REBOA use. But in the subgroup that require laparotomy for trauma, in other words, those that have got a non-compressible hemorrhage, mortality has not improved over the same time frame, and it can remain as high as 50%, depending on exactly what subgroup you're looking at, but 50% in the sickest cohort. But even if there had been some improvements in those numbers, we'd still be looking for ways to reduce that, high mortality rate in the sickest patients. So with that context in mind, this is what I'm planning to talk about. First, what is REBOA? Then the evidence of the effect such as exists. And then I'll talk about optimizing in hospital use for those interested. And then finally, where the future may lie. So resuscitative endovascular balloon occlusion of the aorta, REBOA, is the action of inflating a transluminal catheter mounted balloon device within a discrete aortic segment for a discrete time interval, with the intent of facilitating resuscitative efforts for the patients, chiefly by reducing bleeding through proximal control and prioritizing the proximal circulation to the coronary and cerebral beds, at the expense, of course, of the distal circulation, distal to the balloon, that is. And so another way of saying this is blowing up a balloon in the aorta. And this picture shows REBOA via a percutaneous right femoral sheath, as opposed to the alternative, which is an open cut down, which is, a valid way of inserting a sheath into the femoral artery as well. I'm going to show you about a 90-second animated clip that I think well demonstrates the procedure. It's been made by Prytime. It's a company that develops and manufactures REBOA catheters. You can watch the full thing on YouTube. I'm just going to talk over the video as it goes. So hopefully you can see what's going on there. There's been a sheath inserted to the femoral artery, and a wire's gone in. So sorry, a needle into the femoral artery. A wire's gone in, and that's been exchanged for a sheath. And now, zooming out, we've got the femoral access in the femoral artery, and you choose a level of REBOA. So it's either 1 or 3. 1 is supraceliac, up in the top bit of the aorta. 3 is infrarenal. So I hope you can see that on your screens. Don't go to 2, which is where the visceral segment is. The reason you want to avoid that is you might cause a disruption to the visceral arteries. So you connect the catheter to the arc line, you flush the catheter, you pass the catheter in. This is the pry-time version, of course, and it doesn't require a wire to poke it in. And it passes up the femoral artery, as you can see, into the aorta. So it's gone via the iliac artery into the aorta, and you've either blowing the balloon up, you've chosen how far you're going to poke it in, and you can, decide the length that you're going to poke it in based just on anatomical landmarks. So you can measure it off surface anatomy, and then inflate the balloon. And for pry time, it's 8 cc's in the zone 1 and 2 cc's in zone 2, and watch the pressure change, the pressure trace change, and get the patient to the operating theatre. So here's a picture showing the variety of balloon strategies you can use with REBOA. The left picture segment showing higher volumes of inflation. The balloon will form a circumferential seal with the aortic wall, and that's going to be sustained through each cardiac cycle, and that's called total or complete REBOA. And the middle picture segment is showing at lower volumes of inflation, there's going to be some blood flow in continuity down the aorta, so-called partial REBOA. And then the right picture is showing that the catheter's in, but no inflation of the balloon. The catheter itself may actually materially interrupt flow down the aorta, depending on the relative size of the catheter to the aorta, but particularly to the access segment. So when it's coming up the femoral or the iliac segment, it could, if in young people, these arteries are not huge arteries, and it could cause some flow disruption. It's inserted retrogradely, so it's going against the blood flow. That's all that means. And there's some alternative strategies. Basically, the strategies to use in inflation alternate between those 3 states, or you choose one of those states and stick with it. So the physiological principles providing the desired effect, and the desired effect being, better perfusion to the coronary and cerebral circulation. So this is looking at the coronary circulation. It involves increasing the aortic pressure, because if you increase the MAP, the mean arterial pressure, then you're going to have a higher coronary perfusion pressure. Now, the right atrial pressure may go up to a degree, but not, not to such an extent that it offsets the coronary perfusion pressure. And then Pasquale's law, the pressure difference is proportional to the blood flow, and you get the same fluid principles applying to the cerebral circulation. So that's the physiology behind why the balloon works. So or why the pressure is increased. So what's the evidence of effect then? Okay, well, as Maya Angelou says, you can't really know where you're going until you know where you've been. So our medical forebears have used balloons in the aorta for some time. This is Lieutenant Colonel Hughes. He used a Foley catheter in the aorta on 3 war-wounded casualties in the 1950s, and it was inserted directly up the aorta at laparotomy in a retrograde fashion. Unfortunately, none of them survived, but the proof of concept was there. Heimbecker used them for Canadian abdominal aortic aneurysm rupture patients, coming down the aorta in an antegrade fashion. So that's a Foley catheter in an antegrade fashion. Wolf was the first reported use, to my knowledge, in penetrating civilian trauma, and that was in Cincinnati in an antegrade direction. So he came down from the brachial artery. And Gupta's series for civilian penetrating trauma patients in Brooklyn in a retrograde direction. You can see he was doing zone 1, his team was doing zone 1 REBOA, and they had a number of survivors. So what's the theme here? Well, these individuals were all surgeons, and they were using a technique as an adjunct to laparotomy. And I'd say something else as well. I think regarding the sort of historic aortic balloon use in hemorrhage control situations, I think probably, this is my guess, but most surgical institutions that provided an aortic aneurysm repair service, from 40 years ago, would be familiar with the technique of using a Foley catheter for proximal aortic control, certainly, during the operation. And second, the value of balloon devices for hemorrhage control in surgery has probably been known for at least 60 years, since Fogarty, started with his balloons. And the Fogarty balloon catheter obviously originally developed really for removal of clot, not for hemorrhage control in those rheumatic heart disease patients. So surgeons have been seeking rapid solutions for aortic control other than clamping or manual control for some time, and have had access to the means. They were seeking probably to mitigate the risk in the sickest patients if the hematoma or tamponade was released at laparotomy prior to proper aortic control or balloon aortic control, then rapid death would ensue. So that's where our forebears were coming from when they were using their devices. It's difficult to find anything over the next 20 years published in the English language literature from a trauma perspective on the use of aortic balloon occlusion, although acknowledging data on use was being collected, for example, in the Japan Trauma Data Bank from about 2003 onwards. It's worth noting transluminal aortic intervention was developing in other specialities. Critical care and cardiac specialities use aortic balloon pumps, and they still do. And their first recorded use was back in 1967, apparently. And such devices were first reported to be used in GI hemorrhage and postpartum hemorrhage from about the early 2000s. There could be before that as well. That was the earliest I could find. And also, obviously, endovascular aortic procedures, and they were popularized from about the early 1990s onwards, and percutaneous, so in other words, through the skin, not by an open cut down, but percutaneous aortic balloon occlusion in ruptured aortic aneurysms was being used from about the 1980s. So I think it's fair to say that there was these transfemoral or brachial aortic balloon occlusion techniques going on certainly in most vascular departments in the UK, and worldwide is probably first, certainly in the US and Canada and so on, and Australia from the early 2000s. Okay, so where next? Well, with that history of balloon occlusion in using it in trauma laparotomy in the 1990s and endovascular techniques, it framed the background really for the trauma healthcare community when there was two additional drivers for innovation that came to the fore. And firstly, I think it is fair to say this is the sort of a leader was the London Helicopter Emergency Medical Service and Major Trauma Network were very much maturing. I mean, they'd been around since before 1990, but they were looking to increase survivability in the sickest trauma patients. So that was one big driver for change. And secondly, the American military with the coalition partners were engaged in two wars in the early 2000s, and they were very cognizant of the need to rapidly manage non-compressible hemorrhage and trauma. London, to be fair, probably got there first. They got there before the new generation of REBOA catheters came out. I think that's fair to say. So in 2014, they cited the first pre-hospital REBOA using an over-the-wire coda balloon via the common femoral artery and inflated it just a bit above the aortic bifurcation. So this, which by that I mean above just where the aorta divides into both iliacs. So this device is sited via about 4.5 millimeter diameter sheath. So that's a fairly big sheath that can do some damage to the artery and cause issues for vascular surgeons like me, in repairing the artery and so on. But this was a successful program, and obviously using existing technology, the coda balloon is relatively cheap and available. but they were using it in an innovative fashion. And it required effective and rigorous team rehearsal, and you can see the team practicing in the picture there. And then meanwhile, in the late 2000s, the American, so this is, a few years before REBOA, the London HEMS were using the Coda balloon in that innovative fashion. The American military medical researchers performed a series of swine model experiments to demonstrate the physiological effect and tolerance of REBOA, and showed that it had superiority to aortic cross-clamping in hemorrhagic shock. They collaborated with engineers and designed a prototype REBOA catheter that was bespoke to trauma in 2011. And this prototype, crucially, didn't require an over-the-wire insertion technique into the aorta like the Coda balloon, and it could be sighted through a sheath about 2.5 millimeters in diameter, as opposed to the Coda balloon, which uses 4.5. So that's a small, lower profile device, less likely to cause injury to the artery. This new generation catheter was therefore significantly simpler to use. And the first REBOA publication of the modern era was by this team. And if you look at the authorship, Adam Stannard is a Royal Navy surgeon. And he was a research fellow back around 2009 with the US Air Force Prof. Todd Rasmussen. And so the UK did have a bit of an input to this sort of early work. By 2015, these new generation REBOA catheters were being used in several centres in the US, and the first case series outcome data was published. So while acknowledging there are many different types of balloon catheters you can use to perform REBOA, this is an example of the newer generation catheter. It's the ER REBOA Plus catheter. It's the sort of catheter that's by far the more expensive part of the spectrum. But it's can be positioned using surface anatomy alone to inflate it in zone 1 and zone 3. It allows blood pressure measurement above and below the balloon, and as mentioned, can be sighted through a low profile sheath, a 2.5 millimeter sheath. So that's the background of what REBOA is. Now let's turn to the literature, but I think there's 2 general points to make before looking at the literature. The first is your trauma system, wherever you work, might have some confirmation biases regarding REBOA. I'll give you some examples now of some egocentric biases that may influence beliefs, because we all got ego, right? And you might have a bias for it if you're an individual team performing the REBOA. So this is bias for use. If you see it as a crux intervention that saved or will save the patient's life. Through your manual efforts, you've stopped or reduced the bleeding and preserved vital supradiaphragmatic circulation compared to, say, speedy transfer to the operating theatre where someone else takes over. You might imagine it would take more convincing your friends, your colleagues, or yourself that the effect of a speedy transfer was real, whereas if you're doing a sort of definitive intervention, it's more concrete and plausible, certainly at first look. So, you might say, well, therefore I support REBOA because it makes me feel good in that regard. You may not admit that to yourself, but you may have that cognitive biases. And on the other hand, you might have a bias against similarly, if you were the individual team performing an intervention post-REBOA, you may feel that some other part of the system was taking credit for your efforts or value as a trauma surgical team or individual. And that might make you against REBOA, and you may have that sort of cognitive bias against REBOA. So it will obviously serve our patients well if we try and get beyond that sort of bias and dispassionately look at the evidence such as it is. What else to say about the literature before we look at it? Well, there's different ways to use REBOA, and as you can probably imagine, the complications and the disadvantages will depend on the manner you use it and the manner of the people that were using it in the cohorts that the studies were looking at. So when you're looking at the literature, these are the 7 specific points that I would suggest you consider. Look at the level of the balloon deployment, the strategy of occlusion, whether it's P REBOA, partial REBOA, full REBOA, intermittent REBOA, or whatever strategy is being used, whether using a machine learning to, artificial intelligence to control the balloon, whatever it is, the strategy of REBOA. And the duration of the REBOA inflation as well is clearly going to be important, because that's going to reflect the ischemic root perfusion hit and the supraphysiological proximal circulation flows as well. As in the flow going through the coronary arteries at high speed and high shear stress. And then so that's looking at those. That's really the crux combination. But then you've also got a bunch of factors that might influence the complication profile, and that's the environment of the insertion, whether it's pre-hospital or in hospital, access type, access location, type of balloon, largely affecting the risk of, these sort of things will largely affect the risk of pseudoaneurysm formation and potentially amputation. So there's a massive range of multilateral registry data regarding the use of REBOA in adult patients. The populations have a wide age range, conducted in a diverse range of well-resourced major trauma system environments. Comparison groups range from resuscitative thoracotomy patients to propensity-matched patients, and the outcome is generally measured as survival to leave hospital with some complication profiles being recorded. I'm going to show you a busy table now that summarizes the observational data to an extent. I can't fit everything on one slide. And so that, that's very busy, isn't it? But I'm going to go through a bit of this, and it's basically showing you on the left-hand side, the column is study that you can see in the top left-hand corner, and then follow that down, and you've got some various studies, and then the level of evidence that I've graded, the dates of the actual data, where the data source comes from. PICO is the population, the intervention, the comparison group, and the outcome. So it's a variety of different populations that are being studied when you look at the observational data. So if you go to have a look at the AZO row, so that's the Japanese database. So I'm going to flick off and off this a bit. So survival to leave hospital, odds ratio 2.7 near as damn it, in favour of REBOA. But if you do propensity matched scoring, I'll come on to my view of propensity match scoring in due course. But if you do propensity match scoring, which is where you're trying to match like with like, using essentially a sort of scoring the patient's physiology and so on and so forth, then there's no difference effectively. If you look at the Japanese trauma database up at the top, the population had a mean age of 52 years, and they were 3 hours from the point of injury when they had the REBOAs put in. So that's a different subgroup to a lot of patients that's median time, I should say, that you would see, I'm sure, in your institutions. And then Moore et al., so that's in Texas, showed that they were comparing REBOA to open DTA, that's descending thoracic aorta occlusion, so cross clamp descending thoracic aorta. Those are not necessarily two easily comparable groups. So the ISS score for REBOA of 75 was 6.3 for REBOA. 6.3% of the REBOAs had an ISS of 75, which is essentially an unsurvivable injury, and 21 of the resus thoracotomy groups. So while they did show, look at the last column on that row, they did show a positive intervention, a positive outcome from REBOA. There was not compared like with like. The DTA group was sicker, effectively. And so I'm not going to go through this all in detail, but suffice to say that there was differences in the groups compared. So there's limitations to the observational studies. So so what we have there is up to 2017, commercially available, straightforward to use devices are coming on the market with small sheath access. You've got rapid take-up of these devices in the US and elsewhere as well, Japan, with a growing registry database and analysis in some cases showing demonstrating a beneficial effect. You've got a long-standing sporadic use in the UK. I'm not saying everyone was an expert. There was few and far between, but people were, using the technique percutaneously, sometimes in trauma, or more often in things like ruptured AAAs. And you've also got abdominal aortic aneurysms, and you've also got an active pre-hospital London REBOA program. So it would probably only have been a matter of time before you had widespread rollout across the UK, and not necessarily with a robust body of evidence behind that use. So in terms of clinical equipoise, which is what you need to recruit for a randomized controlled trial amongst clinicians, the UK was as good a prospect as anywhere. And the trial aimed to answer the question, does the combination of standard major trauma care treatment plus REBOA, as compared to standard major trauma centre treatment alone, for the management of uncontrolled torsal hemorrhage caused by injury, reduce 90-day mortality? So REBOA versus no REBOA, everything else being equal, is 90-day mortality reduced. And inclusion criteria included, it was adults, it was 16 years and over, with confirmed or suspected life-threatening torso hemorrhage. The trial enrolled from 16 major trauma centres from about 2017 until it ceased recruitment in early 2022 at 90 of the 120 targeted randomizations because of evidence of harm from REBOA. There was a pause of recruitment during COVID, and I was part of the trial. I think that was for about 12 months. I was looking up, and I didn't manage to confirm that, but I think it was about 12 months from memory. And the median injury severity score of the patients was 41. I'm going to show you now the summary findings first, and then I'm going to highlight some reasons why REBOA advocates outside the UK particularly have effectively discounted this trial. And by the way, this is a free to access paper, so it's not behind a paywall wall, so you can access it yourself for the detail. But here are the summary findings. And because the trial used Bayesian statistics, that's why they quote a posterior probability. So that statistic's essentially saying that there's nearly a 90% chance that REBOA causes an increase in 90-day mortality. And then if you look at it the other way, there was about a 4% probability that REBOA reduced 90-day mortality. So despite randomization, there were some differences in the baseline characteristics. Now, even when there was a multivariable regression analysis done to account for that, the posterior probability that REBOA causes harm or an increase in 90-day mortality was still 85%. If you find it easier to look at Kaplan-Meier curves, those are the Kaplan-Meier curves, and they make the similar point on survival. So you can see top line standard care alone, bottom line REBOA and standard care. So REBOA increases mortality, according to UK REBOA trial, increases mortality at 90 days, increases death due to bleeding at 3 hours and at 90 days, and also REBOA substantially delayed the time to definitive hemorrhage control. So if you're a REBOA advocate, what you'll say at this point is you'll look at the paper and you'll say the REBOA group only had 19 of the 46 patients randomized to REBOA and that actually received the REBOA intervention. And that's what you'll say, and that's what you'll say, and therefore this is just a load of rubbish, because over half the patients that were randomized to REBOA group didn't actually have REBOA. So what would I say to that? Well, I would say that, okay, what happened to the other patients? Well, about 14 had femoral access, but either the catheter was not inserted or was inserted, but the balloon wasn't inflated because hemodynamics had improved. 8 had an unsuccessful attempt at femoral access, and 5 didn't have access attempted post-randomization because of improvement or deterioration. There was also 2 patients randomized to standard care that received REBOA with balloon inflation. So the advocate would say, but for the timely and efficient use of REBOA, the trial would have revealed a posterior probability in the other direction. In other words, it would have shown a REBOA was favourable to reduce mortality. However, those in the REBOA, those randomised to REBOA with failed access, slow access, or died from bleeding, you've got to consider all these patients in the round. You can't discount them because what you're looking at is a REBOA strategy in ED. It's not who got a balloon, who got a balloon put up in the aorta, because you're assuming that all the preceding steps are completely successful. Where else can you assume maximal efficiency in anything that we do? You can't. And I think that's the key point. It's the strategy from the moment the patient arrives that you're looking at. Is a strategy of this patient needs REBOA hurtful or not? Okay, point made. This is the first time we used REBOA in a trial in Leeds. And the reason I show this is there were very reasonable times there for inflation, despite it being our first randomization. So like other sites, the training and team rehearsal had been there to facilitate this. So it wasn't a bunch of people that didn't know what they were doing. Okay, yeah, there was some failed access, but even experienced people get failed access, and it can be challenging and it can suck the team in. So in Leeds, we decided to stop using REBOA for trauma in the emergency department following the publication of the UK REBOA trial outcomes. So that's not to say we wouldn't necessarily use it in other circumstances, postpartum hemorrhage, potentially in the cath lab, etc., but in ED as a strategy, we don't use it anymore because of the results of the REBOA trial. So if you're an advocate, you'll go back to the registry observational data, and you'll say you'll discount the REBOA trial, and you say, well, all these studies can't be wrong. So I've just put there all those positive odds ratios showing favour to REBOA. You look at look at the sheer weight of evidence, and what about the propensity match comparisons? Now, as in the pretend, okay, stand fast the Japanese data bank, but the other propensity matched comparisons and observational data have shown, a beneficial effect of REBOA. I don't find potentially matched comparisons as compelling as randomized data. Why not? Well, I think the initial energy transfer to the tissues, the cellular injury prior to arrival in hospital, the patient physiological reserve and genetics that favour survival, these are all factors that can't be directly measured, that are not included into the propensity scoring and matching. Why not? Because they're damn difficult to measure. And so instead we use the proxy metrics, which is fair enough because that's what we've got access to. But that, to me, is not as good as randomized data. So after saying we wouldn't use REBOA for trauma in Leeds emergency department in the current paradigm, there may be circumstances in the future where the device evolves or new evidence is presented for use in a specific select group of patients. You may work in London where you receive patients REBOA in situ, or you might be in an institution somewhere in the world that uses REBOA in hospitals. So with this in mind, and because it was the title of the webinar, I'm now going to tell you how I would optimize the use. First comes decision making, then balancing the risk for and against. I'm now going to show you a busy slide. Don't read the detail. It's more to just show an algorithm. And also, obviously, you can pause the screen if you're watching a recording for this. Don't read it in real time, but you simply need some way of deciding who you're going to put a sheath into early doors, because that's going to be a delaying factor, because you can't just put a catheter directly into the aorta without some form of access. So the principle really is to get early access, and by that I mean soon after the trauma patient arrives, small diameter femoral sheath, and by small I mean the same size as a radial arc line, not big enough to put in a REBOA catheter, but you can use it to do invasive blood pressure measurements, which will give you a more accurate readout on what's happening with the patient. And if you put in something about, radial arc line size, sheath size into the femoral artery, congratulations if you cause harm. I've never seen harm. I should imagine it's almost impossible to cause harm with that into the femoral artery. And I've seen a variety of femoral arteries in my career, and I can say that it'd be very difficult to cause harm with that. So it gives the option of BP monitoring, and it also gives invasive BP monitoring, and it also gives the option to upsize quickly. You have the kit laid out as well if you think you're going to need it, and start to get it out if you're heading down the path of this patient might need REBOA. So if you lay out all that kit that I've got on the table, you're probably burning through about £90. Now, it might be that you know that's too much, but you know, I think in the scheme of things, certainly in the UK, overall cost, that's not a lot. Don't open the REBOA catheter until you're going to use it, because that's certainly, if you're using an ER REBOA catheter, you know, you're looking at over £1,000. So, but having the stuff laid out on the table, you know, and things packed neatly away in a bag in a logical order will help. Have a checklist probably, or an aid memoir, because you're not going to be using this probably, or you might be using it often, in which case you might not need an aid memoir. But if you're not using it often, which I think is going to be in the vast majority of cases, aid memoir, tick box helps. Decision making still. Consider the alternatives. So what are the alternatives? And it's not simply you know, a resuscitative thoracotomy. The first thing is no aortic control. Just get them to the operating theatre and get definitive control. You can do, you know, open the chest, do a left lateral thoracotomy and press on the descending thoracic aorta, or do a clamshell if you want to look at the heart, and so on. And then instead of doing manual control, you can get a clamp on. And then you can also, you know, put on an external compression device, like an abdominal tourniquet. And clearly something like that's not going to have the same effect as a zone 1 REBOA. That's going to be squeezing the infrarenal aorta. But it will have, you know, it's the same concept as a zone 3 REBOA. What else do you need in the framework? Well, you need a good functioning, well-resourced major trauma system. There's no point in doing this in a low resource environment, because it's a bridge to nowhere. You need blood products, you need, you know, almost certainly you'll need ICU support afterwards and that sort of thing. You appreciate that a target group of patients will need, you know, expert pre-hospital care to arrive in hospital alive, the group that you'll be using this in, and they'll need, you know, hemodynamic resuscitation, rapid definitive control, and critically restoration of perfusion as soon as possible. The clock is on as soon as you inflate the balloon, particularly if it's in zone 1. Every minute is going to be an increase in mortality. And I think it will start to profoundly increase above 20 minutes of zone 1 inflation. Zone 3, you've got longer. You've got, you know, you have up to 90 minutes. Zone 1, if you go above 45, it's death. You know, essentially. There'll be some people that will disagree with that. Certainly total complete REBOA, but it's essentially death over 45 minutes. And, you know, anything above 20, you're starting to, you know, rapidly increase mortality. Now, people will say, well, partial REBOA, you've got longer, and that's true. And it depends on, you know, how much flow you're allowing past the balloon. But if you're allowing a lot of flow past the balloon, at some point, you've got to say, well, what am I actually doing here with the balloon? Okay. Sheath management plan, Hepsal flush, earliest removal possible to stop the sheath complications. And then you'll decide on whether you're going to do a thrombectomy or remove and press. I have to say, my experience is just remove and press, but I've not seen any pre-hospital REBOAs put in. If you do pre-hospital REBOA and you're using a large sheath, then you're going to cut down and do you know, have a low threshold for doing a thromboembolectomy. So there's various pitfalls, and then there's various mitigations to watch out for as your team. So first of all, selection of patients. You can get shop mimics, of course you can. just because someone's got a low blood pressure doesn't mean they're bleeding to death. You might say they're bleeding to death until proven otherwise, but you've got to, if you say that this low blood pressure in a trauma patient's hypovolemic shock to prove otherwise, you will be looking at some of those patients will have shock mimics. So if you use the Hateful Eight, and I'm sure that's been discussed on previous webinars, that's a useful thing to do. You can use something like the rabbit score, which is, ultrasound, is it penetrating, is the pelvic fractured, and what's the shock index? Though, score 1 for each of those. If it's shock index above 1 and anything above 2 suggests you're going to need a major transfusion. So that sort of thing you can use, or just your clinical gestalt. There's an opportunity cost. And I've already said, get your kit ready, get microsheath access to limit that, dead time. Super physiological coronary flow. So if you're blowing a balloon up, you could over resuscitate, give more back pressure into the heart than you need. So you probably want to target the proximal blood pressure at about 110 to 120 to give good coronary flow, and then let anything else go south to give, as Joe DeBose would say, the viscera a bit of a drink, so that you're feeding the viscera. So that's a reasonable, partial REBOA strategy. You can nuance that however you like. So that comes on to the distal ischemia pitfall. Use partial REBOA where possible. And maintain the momentum, even if that's the CT scanner, but most likely to definitive control. And then in terms of sheath or device complications, have an index of suspicion for aortic dissection. If someone's crashed into a lamppost on the motorbike, you might be dealing with an aortic dissection. I have put them up in aortic dissections and not had a complication from it, but avoid, where you've had where there's been a traumatic aortic dissection, but you probably want to avoid that, because if you cause issues there, then that's, in combination with major trauma, that could be a death sentence for the patient if you aggravate the dissection. Monitor insertion length and fix. Don't let it fall out. It easily migrates the balloon certainly once it's up. And then early sheath removal to reduce the risk of sheath complications. Run some sort of readiness program, rehearsal, that sort of thing. These, if you're starting out, these will be your debrief points, a guarantee. And this is what we had, which was avoid, team task fixation, everyone staring at the person doing a REBOA and ignoring the rest of the resuscitation going on. If you've got having an assistant is the most efficient way of doing it, because then you can have someone clean, someone dirty, and so on to hand stuff, and try and get a shared mental model on exit strategies. By that keep momentum going, and have things. A code red pathway is something along the lines of having the right people there, having the right full trauma team there, and having the product you need, so that you're in a good place for the other resuscitative imperatives of the trauma. So if someone arrives with REBOA in situ from the pre-hospital space, so you inherit someone with a REBOA, then these are the things that I would do. I'd confirm that the indication was appropriate, that the balloon is in the advertised zone that they're telling you it's in, that the catheter is actually in the aorta and the balloon is appropriately inflated. And how might you do that? Well, you can check the length. Certainly if you've got one of these ER REBOA catheters, it's got length markings on it, so you can see how far it's in. I've not told you the measurements, but you can see there it's 46 centimeters for zone 1, 28 centimeters for zone 3. You can look at the waveform to make sure it's a arterial waveform and not a venous waveform. And there's radio-opaque markers on it. You can exchange you take the balloon down and put in some omnipaque or contrast into the balloon, take an X-ray and make sure it's in the right place. If you're really fancy, you can also do I've not got a picture there, but you can also do an ultrasound scan as well. I've never done that, but technically you can do it and look at it in the aorta. So, okay, we talked about what is REBOA. We've looked at the literature, and I've given you a way of hopefully a way of optimizing, your own practice of REBOA. Now let's look at what's on the horizon, or where next. So there's no doubt about it. The United States are using REBOA, and are using it in quite a lot of in quite some quantities as well. So this is the new REBOA balloon on the market. It allows you to more accurately control partial REBOA. It's got ridges in that balloon that allow a more controlled deflation without going from full REBOA to zero REBOA almost in one step. You can nuance it with a more accurate partial REBOA. There's a pressure release valve there to stop you overinflating the balloon and causing, these are non-compliant balloons, but causing these are compliant balloons, but causing injury to the if you overinflate, you can either potentially rupture it or potentially cause injury. It's more likely to rupture. And so with these sort of partial REBOA techniques with these balloons, people have been reporting over 2 hours of inflation time. I'm completely skeptical of that. I just, if you've got a balloon in the aorta up for 2 hours, what's going on? Why do you need a balloon for 2 hours? What's that doing? I think the patient was going to survive regardless of that balloon. There's been 800 uses in 10 level 1 trauma centres in the States of this particular catheter. And they're reporting, good results. There we go. That's observational data for you. And they would argue that they've got better trauma systems than we have in the UK, and so that's why they're seeing a difference. But my view, I think you need to get them to definitive, surgical control, definitive hemorrhage control as soon as possible, rather than messing about with REBOA. If there is efficiencies that we can make to get people to definitive control, whether that's in a hybrid, an IR suite, or an operating theatre. You can get things going in a quicker time, and potentially we'll see some improvements in survival from trauma laparotomy. So in the future, there's still a role for using balloon catheters. So certainly in pre-hospital REBOA state, London still use them. They've got a well-developed service there, and the UK REBOA trial is not saying anything about the effectiveness of pre-hospital REBOA. They're used in other contexts, such as obstetrics and in the interventional radiology suite and so on. And then I think what does the future hold in the UK? Well, we need to observe use overseas. And there might be a paradigm that we look to that eventually changes views here, that might work, and it might be in a specific subset of in-hospital patients. So in summary, the in-hospital REBOA for trauma in the UK. Major trauma centres has got a survival disadvantage, and use continues worldwide, and new insights may appear. I think we do need to be cautious that anyone who says we're only a few efficiencies away from getting it to work, I'm skeptical about that. We've still got to continue to look for improvements in non-compressible hemorrhage management. That's me. Thank you very much for listening, and now I stand by for any questions you might have. I'm going to stop sharing.
And I'm going to appear. So let's have a gander where this is. It's here. Wonderful. So thank you very much, Tim, for that. Certainly started a bit of a... where have my questions gone? You pop them up and then they disappear. Apparently people don't want the questions to appear tonight. One sec. There they are. They disappeared behind my screen. So we'll start again. So it definitely brought up some healthy debate that tonight, which was, I do quite like seeing it in the chat, because I think it's always good for people to get opinions out and see both sides of the coin, really. Before we move on to the Q&A, though, I do just want to draw attention to our next webinar, which is happening next Wednesday. So next Wednesday, we will be joined by Wasim Ahmed to start part 1 of our two-parter webinar, The Elephant on the Road, Emotions in Pre-Hospital Care, part 1, The Patient Encounter, with part 2 happening 2 weeks after that, as soon as we get back from Scotland. Scan the QR code that's on your screen now. Wasim was going to be talking to us. It's kind of based around the mental health side of stuff, but it's also based around your decision making as practitioners and your decision making in pre-hospital care and what you can do to improve that decision making. So it's very pertinent, very relevant for everything that's going on. So, questions. And of course, as usual, if you are not a trauma care member, please do scan the QR code that's on your screen now to get your CPD certificate. So if you scan the QR code, it'll take you through to a type form, which you fill out, and then you pay just a simple £1.99, and then your certificate is sent straight to your inbox. If you are a trauma care member, don't scan. Just leave the QR code where it is. I will send you your certificate tomorrow. If you are not a trauma care member, do scan, and you'll get sent your CPD certificate. On to the questions. So Max Marsden. Oh, Max, lovely to see you. The manufacturers of the AAJT make some sound arguments for the use of the AAJT, albeit probably with less evidence nonetheless. Should our next NIHR-funded RCT randomise patients to REBOA or AAJT? Mouthful.
Max, that's a great question. I'm not quite sure in my mind, sitting here now, that we can randomize against REBOA, because I think we'd probably have to randomize against standard care. I'd be all for looking at considering AAJT, randomized trial. It's something that each institution would have to look at and discuss, amongst themselves. That's the abdominal tourniquet, junction tourniquet, by the way, for those uninitiated. So I would have thought it would have to be against standard care rather than REBOA.
Perfect. Thank you very much. And very simply, Jayanta has asked why you're not placing REBOA in Zone 2.
Yeah, that's another good question. Well done, Jayanta. So these balloons that are being used are compliant balloons. So they deform to the shape of the vessel that they're being blown up in. But if you blow them up in close to what's called the ostia. Now, if you imagine the aorta, it's like a pipe, a tube. And from the, forgive me if I'm saying stuff that you already know, but from that pipe, from the tube, there are visceral arteries coming off to the organs. And the origin of those arteries coming off the organs appear in the aorta as little holes called ostia, because that's obviously the route that blood's taking. If you blow a balloon up in that area, there's a risk that you might dissect the ostia. You might rip the ostia, because it's providing a shear stress that's not really fully distributed across the aorta, but it's put a shearing in that particular region of the ostia. So it might rip the lining, it might rip the intima of the aorta, and then you might get a dissection. And the dissection is where the intima lifts off, and that can occlude an artery. So you can imagine if you blow a balloon up in Zone 2, you could occlude any of the visceral arteries. You might, in other words, stop the blood flow to the liver, to the bowel, to the kidneys. One of those, a combination of those, could be deaths. So avoid Zone 2. People will have inflated these balloons in Zone 2 accidentally before, I'm sure, and they will have got away with it. But as a rule, avoid it. There's no real advantage to doing it.
Brilliant, thank you. And Paul Parker, good old Paul, hello. Tim, what are your views on, going back to almost to the first question a little bit here, but what are your views on abdominal aortic tourniquets and foams?
Yeah, Paul's a very experienced trauma surgeon, one of the, or if not the most, experienced and senior military trauma surgeons, and Paul does advocate for these abdominal aortic tourniquets. I'm not. I think it would need a randomized trial to convince me that these were of use in this cohort of patients. Now, I think junctional tourniquets is different. Junctional tourniquets, where you're putting pressure on like a junction, like a femoral wound or something like that, stab wound. That wouldn't take much convincing for me to say that, that's a good thing and will save lives. Squeezing someone's middle to compress the aorta and for equivalent of a zone 3 effect, I'm not convinced about personally, and it might be that I've just got a conceptual or cognitive bias against it. I don't know. I'm quite relaxed about the fact that it compresses the cava as well, because some people say, well, these abdominal tourniquets, they compress the cava. But if you blow a balloon up in the aorta, certainly total REBOA, then you're going to be shutting down a lot of the caval flow anyway below the balloon, because that's just the way the circulation works. You still get some venous return, but it will shut down quite a lot of the venous return. So it's not really for that reason. It's more the sort of general concept of squeezing someone with trauma. But I'm keeping an open mind.
Brilliant. Thank you so much, Tim. And hello, Keith. It's good to see you. So Professor Sir Keith Force is in the audience tonight as well, our honorary secretary. So it's wonderful to see you. And Paul, just so you know, because I know you were concerned about my knee, luckily it was only a partial tear. So we're all good on that point. He asked me to go see him in surgery in Birmingham. But brilliant. So, I always say this, I say it's the last question, and suddenly everyone gets a bit brave and starts coming in. So David, I'm going to say Mashin, apologies if I pronounce your name wrong there, has asked, is there any evidence for REBOA in non-traumatic cardiac arrest as a future concept?
Yes, certainly. And people have published on it and they report, good outcomes. And conceptually, it makes sense because it's increasing the mean arterial pressure in the aorta, as we saw on that physiology. It also potentially has a vagal effect as well on the baroreceptors in the carotid and the aortic arch. So conceptually, and people have reported some success on it. So yes, there's almost certainly a use.
Perfect, succinct and wonderful. Sean Santos, or Sean, I'm not sure, sorry, has asked, London HEMS have been very open in their use and approach to a thoracostomy in trauma and how they have nuanced its use. Do you have any feel for their approach to REBOA, and may we see some changes in their approach?
Sean, good question. I'm not entirely sure I fully understand it. In terms of, I'm not quite sure what HEMS are doing, how they've nuanced their approach to thoracostomy. Sorry. Presumably they've got a bit of a they've nuanced their algorithm or something, and they're sort of more targeting people. Are we talking about thoracotomy rather than a thoracostomy? Presumably not finger thoracostomies, but thoracotomy, opening the whole chest. And maybe they're doing it in a more targeted fashion. I just making that assumption. Yeah, if that's the case, then yeah, there might be a future use for REBOA in a nuance in a subset of patients. For example, the femoral stab wound. Putting a balloon up on the contralateral side, in zone 3, very rapidly, you can imagine how, to get control might benefit that patient, that sort of patient. You might not be able to show a mortality benefit, but it might be benefit them from not, less morbidity from blood loss. And the first clot is the best clot, and so on and so forth. Yeah,
and you are correct.
Sean, my assumptions were correct. That's fine. Thank you. Yeah, I think
I did think. Yes, I did think when I read it. So yeah, and I'm going to say last question for now. And as soon as I look away and look at my screen, I can guarantee something's going to pop up in my right eye here. So brilliant. Thank you very much again, Tim, for joining us this evening. It was, as everyone said, a well thought out, brilliant, balanced, clear presentation. And even for someone with as minimal medical knowledge as I've learned a lot from this evening. So thank you very much.
Thank you.
And of course, As always, before we leave, just a quick shout out and thank you to our sponsors as well. QualSafe, who will be joining us in Glasgow, of course, because the lovely Toby McLean from QualSafe has helped us put together the entire event. Scan the QR code that's on your screen now, and you can find out all about their courses, of which I think they've launched about 10 more in the past week as well. So definitely worth checking out to find out more about their first aid courses and FREC 4 courses they have available. And Galen as well, who are wonderful. I can't say too much about them without sort of breaking their not laws but bylaws, so to speak. But if you want to find out more about Galen, do scan the QR code that's on your screen now. Go to galen-pharma.com, click on the I am a medical professional tab, and you will be able to see all the wonderful products that they have available that you can recommend to your leads. Thank you, Galen. They are very good friends of ours and will be, I think they're coming to the FIT course, but they normally do. So hopefully we will see them there. And of course, thank you to you all who have joined us this evening as well. It's great to see a lot of familiar names in the audience. Some I've not seen for a while, so it's lovely to see you all. Of course, wherever you are in the world, as per usual, please do take care of yourselves, your families. It's Mental Health Week as well, which is always important to me and important to trauma care. So wherever you are in the world, thank you for joining this evening. Take care of yourselves and good night all.